So real-world data refers to any data that is collected outside of a randomized controlled trial or RCT setting. The evidence, the clinical evidence that is generated on the basis of real-world data or RWD is called real-world evidence or RWE. Now, RWE in itself is hugely important for a number of reasons. First, it helps us identify areas of unmet need within oncology and also in terms of health services research in cancer. It is also important to understand how some of the newer treatments, which have only gone through clinical trials, how they work in an unselected groups of patients in terms of their true efficacy or safety or toxicity profiles. And the patients in trials, you have to remember, are usually highly selected. They differ from those in the real world in terms of age, the number of lines of treatment, the pathologic or tumor genomic events that are tested for, and the cancer aggressiveness that are included in trials. And so it is really important to see how treatments and health services behave in situations that are not part of trials. Real world evidence is gradually being used by regulators and those who are making decisions on whether to introduce a drug in a specific company, or by policymakers in charge of insurance reimbursement to decide on new treatments in their populations. But there is a certain reluctance to accept real world evidence, primarily because it comes from observational epidemiological data, and these data are not always ready to use for causal inference, unlike randomized controlled trials. And as a result, within academia especially, there's a reluctance to be part of RWE studies, and pharmaceutical companies might be reluctant to sponsor these studies. But things are changing very quickly, and there is increasing optimism about real-world data and evidence. And in terms of developing countries especially, there's a massive shortage and unmet need for generating more real-world evidence. So I'm really excited about this special issue on real-world evidence and data in breast cancer across the world. There are 5 papers in this issue, primarily from Latin America, but also one paper from India. The first paper, I'll go over all 5 in brief, but you should read the issue for the details. The first paper is led by Evelyn Bias-Lozano and Yanin Chavarri Guerra and colleagues from Mexico. It looks at poly-ADP ribose polymerase inhibitors or PARP inhibitors, principally olaparib and talazoparib. Now, these are drugs that are used in BRCA1 and 2 mutated breast cancers, which account for around 5% of all breast cancers that are diagnosed, and specifically in the HER2 or HER2 negative subtype of breast cancer. Now, they've been shown in phase 3 studies to be, such as Olympia, Olympiad, and Embraca, to be safe and efficacious in both early and advanced settings in breast cancer. But these studies did not include older patients, heavily pretreated patients, or patients with poor performance status. So our colleagues from Mexico in this paper really review phase 4 studies. So those are the sorts of studies that come after clinical trials, expanded access cohorts, and retrospective cohorts to look at the evidence for expansion of the profile of use of PARP inhibitors in the subgroups that I just mentioned. The second study is led by Fernando Petrasi and Pablo Mando and other colleagues from Argentina as well as Mexico. They present a prospective study of a relatively small but valuable sample size of 50 patients with detailed biomarker and follow-up outcomes data, representing the first such collection from Latin America, again for PARP inhibitor use. in the setting of germline or somatic mutant BRCA1/2 breast cancer, or if the breast cancers were carrying homologous recombination repair gene mutations. Now, real-world versions of objective response rate, progression-free survival, and overall survival were used by this group to follow up the outcomes of their cohort. Objective response rate was defined as the best response in the first 6 months as per RECIST criteria. The key findings is from their work is that the objective response rate was 47%, which was lower than that seen in the phase 3 studies, which in turn was 60% or just above that. However, the median progression-free survival was 7.7 months, which was comparable to that seen in Olympiad and Embraca of 7.4 and 8.6 months, respectively. Now, amongst those who progressed, interestingly, 1/3 of the progressors were due to visceral metastasis or visceral crises. And these rates were higher than the corresponding rates in the phase 3 trials. Only 4% of patients discontinued their therapy due to adverse events. The third paper comes from Katsuki Tiscosi and Gustavo Vertusky and colleagues from Brazil. They look at a review of the state of breast cancer, particularly triple-negative breast cancer, or TNBC, in both Latin America and Caribbean countries. Now, as many as 40% of breast cancers diagnosed in the region are of the triple-negative subtype, whereas only 10% of breast cancers in the developed world are TNBCs. 80% of healthcare in the region comes from the public sector, but not surprisingly, but somewhat unfortunately, the access to newer treatments within this public sector is quite limited. For example, for immune checkpoint inhibitor, anti-PD-1 antibody pembrolizumab in the metastatic setting, and PARP inhibitors, these are only available in the public healthcare system in Argentina and Colombia, and only available in private healthcare in the other countries, which makes up for a very small proportion of overall healthcare in these countries, the private healthcare. So they also look at genetic testing, and only 7% of those with BRCA germline mutations, those who need testing, are picked up. And also the concordance of immunohistochemistry for even a well-defined receptor such as HER2 between local labs and reference labs is only 33%. So there's a lot to be done in terms of both genomic testing availability and the availability of newer treatments in these regions. Next, the fourth paper comes from Benjamin Walbaum and Cesar Sanchez and colleagues from Chile. They perform a retrospective study looking at specifically a new cyclin-dependent kinase inhibitor, CDKI, palbociclib, which is used alongside endocrine therapy, rather, in hormone receptor positive but HER2 negative advanced stage breast cancer. Now, they look at the problem here is that most breast cancers in the countries that they look at, particularly Chile, are only treated with palbociclib in the second line, and it is only in this setting that insurance reimbursement or public health access to this drug is available. But what they find is that in their cohort of about 105 patients, that of the 67 patients who receive first-line palbociclib along with endocrine therapy, they perform much better than those who receive palbociclib as a second-line treatment alongside endocrine therapy, or those who don't receive palbociclib at all. In fact, the 5-year survival rate in the first-line palbo group was 89% versus only 43% in the other group. This makes a case for extension of reimbursement in the public health system for this drug as first line rather than second line. And the final paper comes from India, from Neeta Kurian and Aju Matthew and colleagues. Now, this is more of a health service research paper where they look at the problem of early detection of breast cancer. Now, breast cancer is often not detected early in a setting like India because the medical system, the access to it is poor. There are financial worries, there's a lack of awareness, and there's a fear and stigma around cancer. So what they do is create a 4-minute video publicizing the risk factors for breast cancer and giving you information on breast cancer. They publicize this via social media, physical posters, and as part of a local health promotion campaign. And a telephone helpline is set up, manned by junior public health nurses who receive a specific training program in breast cancer. And over a year, they followed up how this telephone helpline responded to callers. Out of 400 plus callers, only 122 had never consulted a doctor. They called in with breast symptoms. And after being given the information that they required over the telephone call, 78 of them reported contacting their doctor. And after contacting their doctor, as many as 14 of them were advised for workup for breast cancer, while the rest were found to have benign breast disease. So this is a way of extending access to early detection of breast cancer and downstaging breast cancer at the stage at which it's detected for better prognosis in a setting like India or other developed countries. So the future of real-world data and real-world evidence generation is quite promising. However, then there are a few challenges that need to be addressed over the next few years. As you would have seen from the 5 manuscripts or papers, rather, in this special issue, we need to move towards a more uniform and homogeneous framework for real-world data collection and RWE generation, as is already the case for clinical trials. Across the world, social media and smartphones and digital apps are quite pervasive, and we need to explore the use of these as sources for collecting real-world data and evidence generation. And finally, a lot of the newer drugs are very expensive for use in low-middle income settings, and there's a tendency towards value-based pricing. And we need to understand what is the value that patients in these countries actually assign to these drugs, and move towards a regime where we have value-based but tiered pricing, where the value for these drugs is essentially priced according to the value that the patients attach to them. So I think these are the 3 main directions that over the next few years we feel as a field that our real-world data generation has to move towards.